can get started. I thank you all for coming to my talk today. I'm very, very appreciative of this. My name is Sumeet Vadera. I'm a epilepsy neurosurgeon at UC Irvine, just down the street from here. I've been here for about 10 years. I did my training at the Cleveland Clinic before that, where I did neurosurgery and epilepsy surgery. And then I was fortunate to come here and start my practice treating epilepsy patients. And in the last 10 years, we've been very fortunate because we've had just such a huge need for epilepsy surgery, and we've been able to help a lot of patients, and some of those patients are in the crowd already, so it's great to get to see you all. So today I was asked to give a talk on the advances in LITT therapy, which is essentially laser therapy for patients with epilepsy. And so I'm going to show you, give you a little bit of a history about this. I'm going to talk about the type of patients that do well with this surgery. I'm going to show you a little bit about how it looks to do the surgery. Before I do that, I'll give you, anyone who gets a little queasy looking at that kind of stuff, I'll let you know so you can look away. So this is a picture. I love to show this picture. I show it with all my talks. This picture is about 80 years old, and it shows, early epilepsy surgery. And what you see in the middle there is Dr. Penfield. So he was a neurosurgeon from Canada, and he's operating on a patient who's awake. And in the background, you see there's the epileptologist, Dr. Jasper. And what I really like about, there's lots of things I like about this picture, but one of the things is that you can see here that it's a team approach. So, the epileptologist is in the operating room, the surgeon is taking care of the patient, you have neuropsych in the room talking to the patient. All of this is kind of very, 80 years ago, a lot of things have changed, but in a lot of ways, things are, very similar. So I'll tell you a little bit about what the kind of issues were 80 years ago that people were struggling with when they tried to understand how epilepsy surgery would work. And so what they would say is, patients who have a tumor or trauma to the brain or other injury to the brain, they thought that if you remove that area that the seizures would stop. And it wasn't until, Penfield and Jasper together did these experiments where they would do a large surgery and they would have an electrical stimulation and they would stimulate the brain and the lesion. And what they found was that when you stimulate the lesion, it didn't cause any seizures. But if you stimulate around that lesion, you could actually create people, you could cause seizures in these patients. And so what they figured out was that if you remove both of those areas, you can actually make people seizure free. And so this was a very big deal because until that time, people thought that the lesion itself was causing the seizures. And so thankfully today, we don't have to do exploration surgery anymore. We're not exploring around stimulating the brain. We have lots of non-invasive tests. And so you can see here, these are what some of the tests look like. We have SPECT studies, PET studies, MEG, and high-resolution MRI. So oftentimes when you go to an epilepsy center, they're going to want some of these types of studies done so that we can, using non-invasive testing, figure out where the seizures come from. But I also put this slide in there because it is not just the surgeon, it's not just the epileptologist. Epilepsy surgery very much is a team sport, and I think that the patients do the best when you get, the best care from each of the different treatment providers, and when they all look at you with their, their own specialty and their own eyes, it gives the patients the best care, and the best outcomes. So this is kind of the normal process that we see when a patient comes in. So they're evaluated by the epileptologist, they get special testing, PET study, fMRI. Sometimes we do invasive monitoring, which means we implant electrodes in the brain. And then my talk today is going to be mainly about how we do treatments after that point. So laser ablation is going to be a major topic for the rest of this discussion. So, I mentioned Dr. Penfield. 80 years ago, he was actually the one who invented all these instruments. So we use these instruments every day as neurosurgeons. And some of the benefits are that they were effective and easy to use and safe and durable and time-saving. And part of the reason that we still use them to this day is because they have these really great, we use these on our patients when we do surgery every day. And one of the things about LITT therapy or laser surgery is that it gives us a lot of the same things. And really, I'm going to highlight the safety part of it, as well as the ease of use and the effectiveness. So we're going to talk a little bit about epilepsy. So one of the benefits of doing these laser ablations is that they're minimally invasive. So in select patients, when they have certain types of diseases causing epilepsy, we can use a very, very thin, it's about the thickness of a guitar string, and we make a pinhole opening and we can pass this laser fiber into the deep part of the brain, and then we can bring the patient to an MRI machine and we can actually watch that ablation happen in real time. So I turn the device on, I can actually watch the ablation occurring on the patient in their MRI, all happening in real time. And some patients, we've shown that they have better neurocognitive outcomes, so maybe they do better in terms of their cognition after surgery. And the other benefit is that they oftentimes can go home the same day or the next day. And so in a lot of ways, it's a really great option for certain types of patients. At UCI, we've been fortunate. We've had a lot of good experience with the laser. We've written a lot of papers on it. I'm going to show you what the process looks like. And so, like I said before, I give you kind of a heads up. If you don't want to see anything, a little bit more surgically related, then just look away for a couple of slides. So this is what it looks like. And what you can see here is that there's a very, very thin, almost like a guitar string. That's about as thickness of the fiber. This is what it looks like after it's implanted. So this is the actual robot. It's moving into position. So you can actually see the robot that we use. It's right outside the door. That's the ROSA robot. And then we use a drill to actually get into that area. Then I use a stylet to very, very carefully make a tract in the brain, which is then what the laser fiber is going to follow. So you can see here, this is us placing that fiber or that stylet. And that, again, is what the fiber looks like at the end of our procedure. So as I mentioned before, this is not a surgery for everyone. Certain diseases are much better treated by laser. And so these are the specific ones that have shown really, really good outcomes. So mesial temporal sclerosis, which is when you have a very, very small hippocampus and amygdala, which is oftentimes the cause of epilepsy. In adults, mesial temporal sclerosis is the #1 cause of epilepsy. And so people who have this kind of a problem, sometimes they benefit from the laser surgery, even more so than some of the other patients. Heterotopia, hypothalamic heterotopias, corpus callosotomy, these are all different procedures. And I'll talk very, very quickly about each one. But my goal here is mainly just to give you kind of a broad overview and to understand that there are these really exciting technological benefits to doing some of these types of surgeries. So you can see here that this is what a patient had, this mesial temporal sclerosis. So just to orient you, you can see here that they're looking at you. I don't know if this actually. Are you able to see my? Okay, great. All right. Does that show up or no? No. Here. So right about here. You can see in this spot, perfect. So this patient has mesial temporal sclerosis, and as I mentioned before, sometimes in certain patients, you can actually do laser surgery to treat that. Other times, this patient here, you can see on this side, they had a large temporal lobectomy. Temporal lobectomy in terms of open surgery is our best surgery for treating patients who have epilepsy. Seizure-free rates are in the range of 60 to 80%. In certain patients, though, instead of doing that larger surgery, we can place that small laser fiber into that area and then just burn that tissue and get a similar result. So I'll show you what that looks like. You can see here, this is that laser fiber. So the patient had a laser fiber placed in the back of their brain very, very safely and with that robot. And then we use the MRI machine to actually watch that ablation happen in real time. So what you see here is that white outline that I'm showing you right here. That's actually what the laser ablation, that's what it looks like at the end of the surgery. So I did a little bit of literature review to look at some of the more recent papers on this type of work. And essentially what it, to kind of give you just a basic outline, it says that open surgery still is the kind of gold standard. The 60 to 80% of patients who get seizure-free, that is the best option we have. Laser surgery, on the other hand, is a little lower. It's on the range of about 50%. If you get a laser surgery and you continue to have seizures, then you go on and have open surgery as the next option. So periventricular heterotopia, also very, very difficult treatment, very difficult thing to treat. These are very small lesions. I'm going to show you right there. It's hard to actually see it, but it's usually, I tell people, about the size of a Tic Tac, and it's very deep in the brain. For us to do open surgery to get to that area means that we have to, cause a lot of collateral damage. We have to get down to that deep area. If I did it open, and I would, cause injury to some of the surrounding tissue. The beauty of this procedure now with the laser is that you can see here, this is actually the laser fiber right there. And it's sitting right inside that little heterotopia there. And then when we do the ablation, I'll show you what it looks like, when I'm looking at it on the MRI screen. So it starts off, this is the initial heating phase. So you can see here there's just a small area of heat starting to develop. And then as time goes on, it starts to actually cause more and more of a thermal injury. So at that point now you've actually created, like I said, that Tic Tac sized ablation. And just by treating that area and the surrounding tissue, you can then get something that looks like this. So you can see here, very, very small ablation. But in patients like that, we have very good seizure-free outcomes as well. So looking at the literature, we talk about in the range of 50, 70%, depending how well you can ablate that area. So again, in very certain specific types of disease processes that cause epilepsy, we can have very, very good outcomes with a very, very small surgery. This one, hypothalamic hamartoma, is probably one of my favorite surgeries to treat with the laser, because what I tell people is that if you imagine where this is located, if you took a basketball and you cut it in half and you floated a Tic Tac right in the middle of it, and then you said, well, I'm going to give you a guitar string and I want you to pass it in and get to that any farther, too deep, too shallow, don't go a millimeter up or down. That's exactly what we have to do with the laser fiber, and that's how this surgery works. But the reason I like it is because it is an incredibly good surgery. We have like almost 80% seizure-free rates for people who have that kind of a problem. For us to do an open surgery, there is really no good open surgery option. One option is we travel all the way from up here all the way down to that area, which can cause a lot of additional damage to surrounding tissue. Or we come from below. No matter how we do it, it's a very, very difficult place to get to. So having a laser and being able to do this surgery and not affect anything else in the brain really is kind of one of the best options and best ways to treat this. Corpus callosotomy. So this is another surgery that we do, oftentimes in people who have seizures that cause them to fall down. This is like a very, very bad type of epilepsy because you can imagine people come in and they have to wear a helmet because they fall down and they hit their heads. They've fractured their skulls and teeth and all sorts of very bad problems. And one of the things I really care about epilepsy patients because we see how bad epilepsy can be. We see that on a daily basis. And more than that, even we see how well these surgeries do. And so for people who have that kind of a problem, corpus callosotomy is an excellent surgery. Now, in general, we do, before laser, we would do this open and we would separate a large area that connects the two parts of the brain. Now you can see with the laser, we can actually get that entire section just with the very simple and very, 2 or 3 small laser fiber placements. So very, very exciting. I'm actually really excited about this. This is called RF ablation for epilepsy. This is brand new, very, very early stages of treatment in the United States. And at UCI, we're actually going to be one of the first centers on the West Coast to be using this. So RF ablation is similar to the laser, but it uses a radio frequency, and it's a very low frequency, and it essentially causes a very small area of burning, much less than what the laser does. But what we can do is we can do this actually at the bedside. So in a patient who has intracranial electrodes placed, we can, using that exact same SEEG electrode, like what you've seen outside, we can then place these small RF ablation lesions and burn very, very small areas around that. And oftentimes we can make people seizure-free with this very minimal, procedure, or we can, reduce their seizures significantly. So this is kind of the next phase, and here talking about new exciting technology and techniques, this is something very, very new coming to the United States, and at UCI we're going to be one of the first centers to do that. So very excited to, in the next few months to be able to start treating patients with this. As I said, you can see here the literature shows that patients have very significant, meaningful reduction in their seizures. Sometimes we can do this in a patient and they may have no more seizures, ever again. Other times they may have a 6-month reduction in their seizures, but by doing this, it shows that this is the right location and the right area to treat. And then we can, discuss other options, things like that, that can give people more long-standing, better seizure outcomes. So it's a quick talk because I was hoping we could do more of a discussion or question and answer period. But what I wanted to I hope you take from this is that the laser surgery as well as RF ablation are very, very good treatments for certain types of epilepsy. In patients who benefit, like the types of diagnoses we talked about, those patients do very well with this type of surgery, and it avoids a larger surgery if you can avoid it. Now, in other patients, of course, if you have a problem that needs open surgery and larger surgeries, we're very adept at doing that, and that's kind of the things that we do very, very commonly. This is a great talk to kind of give you a little bit of background and understanding about other types of treatments that we may not, work for everyone, but are really great in certain settings and with certain patients. And so with that, I just want to say, take a bow, Rosa, and then I can sit here. Sat and please ask me questions, and happy to answer anything I think for the rest of the time. Go ahead.
The RF ablation, how new is that procedure compared to its thermal burning counterpart?
Yeah, great question. So the question was, how new is RF ablation compared to laser surgery? So it's very interesting. About 10 years ago in the United States, laser was the number one, or it got approved surgery at one center, they're told, you know what, you had surgery, we did the gold standard treatment, we have nothing else available. And then, they're kind of left to just deal with the seizures. And I think that's really the wrong way to look at things. You have to have hope. You have to keep trying, talking to different, coming to talks like this, learning about different treatments. And I think when you see all those, you can see that there are lots of options available. I never would tell you to give up on it. Are you still having seizures after the surgery?
So I feel thankful that I did have the surgery because my seizures are no longer like, you know, right there that I know of. But like as time is going, I'm seeing like visuals that I'm familiar with, but it's nothing as compared to before I had the surgery. So I'm thankful for the surgery, but I just don't know whether or not to get that procedure that as he offered. So it's just kind of like up in the air right now. He said it's 2 years is the time frame to do that. If I don't want to after the 2 years, then it's not an option.
I wouldn't say that necessarily. I would say that it all the end result of whether you go on and have more surgery or not all depends on are you having seizures? Are your seizures controlled with medication? If they're not controlled with medication, is there something surgically treatable? And I think.
Get you to speak at the mic only because we're recording. We need audio.
Oh, of course. Thank you. Sorry about that. What I was saying was that if really the decision to have more surgery really depends on, are you having seizures still? Are the seizures uncontrolled with medication? Is there something on the MRI that is still treatable? And so that would be really the question. The 2-year, I would never, say that there's any kind of. I can tell you, I've had patients who had seizures their whole lives, and we operated on them at 60 or 80 years old and have made them seizure-free. We've had patients who had surgery as children who kept having seizures. We've made them seizure-free. I think timing and those types of things, I'd never tell you. Everyone's different, yeah. I wouldn't say that there's any hard and fast numbers. Go ahead.
So for the testing that you've done with the laser, what kind of like neuropsych changes have you seen, like a patient that's like either before and or after with these laser treatments?
Yeah, very good question. So the question is, what types of neuropsych changes have we seen when patients before and after the laser? Back and answer that in a kind of broader sense. So we know that when you have, most people who are right-handed are left brain dominant. If you're left brain dominant, that means that your short-term memory and your language are on the left side. When we do surgery, and we do open surgery to remove that area, there is a good percentage of people who have a reduction in their short-term memory as well as in their language. And that can happen especially if you have very good language and short-term memory. There are people who have had seizures for many years, and their memory and their language get to the point where it's pretty bad, and they'll come in and they'll tell me, like, I have to write things down, I don't remember anything. In those people, if we do open surgery or laser, we don't really see any difference in terms of their outcome. It's almost like the floor effect. With the laser, the early studies on the laser showed that some patients who would have had a reduction in their short-term memory and language with open surgery didn't have that with the laser. So you have to weigh that, though, with the fact that it's a lower seizure-free rate. So, I always tell patients, I can't tell you what the right answer is. Some people come in and they say, I want to have everything done. I want to have one surgery, and if I can be seizure-free, I want that surgery, and that's it. Some people come in and say, I want the most minimally invasive treatment, and if that doesn't work, then I would be okay to go and have a larger surgery. And everyone comes in and they surprise me with what they say, and so that's why I never say, do this or I recommend this or whatever. I think it's much more important that you get all the information and you know what the options are, and then we work together as surgeon and patient and the whole epilepsy team to come up with what's the best option for the treatment. So I don't know if that answers your question. Okay, perfect.
I have a couple of questions.
Sure.
When you're doing the laser surgery, when you're doing the laser fiber, does any of the other tissue that the fiber goes into before it gets to where it has to be, does it get
Great question. So just to repeat, the first question is, when we put the laser fiber in, does it damage any of the other brain tissue around where the laser goes into? And the answer to that question is really no. It is like I said, a very, very thin fiber that we pass through. There's complications that can happen. You can cause an artery or vein to get injured, and so we have the robot and other things that help us. I always say, I kind of